the presentation hosted by Amar Patel with CAE and presented by Amanda Wilford. Just a note that by registering for and viewing today's virtual learning lab, you agree to receive follow-up communication via email from representatives with CAE. This session is being recorded and will be uploaded to the online learning section of the SSH website later this evening. If this is your first time tuning into a virtual learning lab, note that these weekly sessions are hosted by members of the SSH Corporate Roundtable every Wednesday at 2:00 p.m. Eastern. And I will now turn the session over to Dr. Amar Patel with CAE.
Thank you, Olivia. Thanks so much, and I'm so excited to be back with you guys. I think we're on number 3 of our wonderful virtual lab tour, and I'm super excited to be here with you. Certainly to be here with a co-host, Amanda Wilford, and you're going to hear more from her than us. But today we're going to talk about virtual and non-virtual. A nursing educator reveals the lessons learned during the pandemic. And so for this modern webinar, we have muted you upon entry. And certainly we will not be using the Poll Everywhere software today, but we ask that you utilize the chat for any questions that pop up. And if there's something specific that you want to mention or ask in voice, just let us know in the chat first, and then we can ask you to unmute before you're able to talk. That way we're keeping with the motion and the time period that's allocated here. If there's questions after the webinar that pops up, certainly reach out to us at training@cahealthcare.com. We're more than happy to get back to you and close the loop there. With that in mind, I'd like to introduce your wonderful speaker for today. Amanda Wilford is one of our group leaders. She's actually responsible for the rest of the world in terms of education and training for us. So we have a group leader that covers the US and Canada, and Amanda covers the rest of the world. So we're super excited to have her. Nursing background, been in simulation since 2000. She actually joined originally Medi back in the day and then became C in 2008. Tremendous amount of experience, both in nursing as well as in simulation, and is heavily involved in both society work through SESAM and the International and INASCO. So super excited to have you, Mandy, and excited to hear all your work with Maestro.
Okay, well, firstly, good evening, everyone from the United Kingdom. I'm going to switch my camera off just because if not, there's a lot of software I'm about to show. So I'm just going to stop my video now on purpose. So, okay.
And Mandy, if you can just reshare, just so I don't think everybody's seeing your screen yet.
Great. Let me just do that. Bear with me. I knew this would happen, so just trying to. Oh, hang on a minute. I apologize, everyone. Just trying to find the share button. We did rehearse this, so this is obviously how not to simulate. Having a slight issue, Amar, finding the share. It seems to have disappeared.
And 1 second, Amanda, I'll see if I can give it.
Oh yeah, I apologize, everyone. Sorry, in the rehearsal, it was stunningly brilliant. So as we went live,
should be on the bottom of your screen. It says share is the green button.
Yeah, no, I'm not seeing anything. So I'm just gonna, there is no, let me just switch my camera back on. Maybe I inadvertently switched something off. I do apologize, everyone, for this. I'm just seeing you, Amar. I'm not seeing any share button or anything. So literally nothing.
All right.
Okay, so let's have a, if I go there.
Sorry, folks.
So I do apologize again. No, I can just see you, and I've got an arrow, my mute, camera, and then just a little circle. I'm not quite sure how to resolve this. Should I just quickly?
It's okay, Amanda. Just a second. I'm going to figure it out for you too.
Okay. So anyway, just why we're doing that, let me tell you what I'm going to talk about, because that will save a little bit of time for us. Is we're just going to talk a little bit about digital scholarship. We're also going to talk a little bit about some of the things that we need to do as simulation-based educators, and then we're going to create a patient journey using virtual technology. So that's what's coming. So, so you will not miss out on anything.
Mandy, do you have share back again? If you go up top, you should be able to now click, it says view share, maybe, or on the bottom.
I'm still seeing the same box that I can see. I'm just going to try and pull it out a bit. I'm seeing something that's really small. I'm seeing it says content, then I see just a really small box with just no controls at all.
Okay, that's fine. If you want to talk,
Okay, well,
why don't we do this way?
I'll tell you what, I will carry on what I was going to talk about, and then because, so what I was going to share with you really is just while we're figuring out the technology, is that I think COVID-19 has really accelerated the process for digital scholarship. And if we think about the work of Martin Weller, he says that for good digital scholarship, it's this marriage of educators, learners, and also looking at some of the resources. And some of those resources may be digital content, and Evolve is going to be one such example, but also maybe using open educational resources. So think about trying to mirror all of that together. So thinking about the journey that myself and my colleague Diane Mattei, who actually has done a lot of this work with me. So it's not just my work, I'm presenting work on behalf of the Academy team. So I really wanted to look at Boyer's model of scholarship. And she talked about that for us as facilitators, and this might be in the broadest term, so I'm thinking here of educators, simulation teachers, simulation technologists, anybody that's using simulation-based education. What we're thinking about is this concept of discovery, the way we can advance our own knowledge, thinking about the integration, so how perhaps we can use our digital technologies with our current teaching type pedagogy, thinking about the application of this, and also this whole networking piece. So Martin Weller is suggesting that for us to transition into digital scholarship, we need to think about that. So what I tried to do was reflect about where we are today from a nursing perspective, but also thinking in relation to the pandemic, which has really been very challenging for all of us. So if you think about that Boyer's model, we can think about new ways of delivering simulation-based education. So we can think about new models, new frameworks. I would say traditionally, we've been doing things like pre-brief, simulation activity, and debrief. We need to think of different ways, whether we're going to use these open educational resources, whether we're going to use things like Evolve that you will see most definitely. Thinking about social media, microblogging, the world of Twitter. Thinking about our sort of the integration, so a blended learning approach, maybe thinking about learning management systems, thinking about cross-learning across organizations. The digital world allows us to work across campuses, across faculties, across the world as we are today. We can also think about us as a facilitator moving into this concept of digital scholarship. Alison King talks about being a sage on the stage to a guide on the side. So again, we can do some things around that. And also our learners are part of this process too. And then also new ways. So I think it's really exciting that in this world, everything that we have is new and it's evolving, and it's a way to be really innovative. And I think we're really transforming the way in which we teach. So this is what sort of Martin Weller is talking about, and this is what I'm going to link some of the work we've been doing with Evolve. So I'm just going to check how our lovely technical team is. And finally, everyone, I can see Michelle, the share screen has come back. So whatever magic you have done, I'm going to say a huge thank you. So we got to the point where I sort of needed to get to. So you've missed some lovely pictures, but please don't worry about that. So I'm just going to share my screen. I'm just going to, just bear with me. So I'm just sharing screen too. I'm sharing, and hopefully what you can see momentarily is a slide of a classroom. Are we there? I think we are. Great.
We are there, indeed.
We are there. So I do apologize. You just missed some really stunningly great pictures. But hey ho, that is the world of being a simulation teacher, is just to keep going. So thinking about digital scholarship and thinking about us as educators, We need to think about our digital classroom. Here's a nice picture of a very traditional classroom, but we're using these wonderful synchronous, such as Zoom and asynchronous tools. Thinking about your IT policy, the concept of digital ethics. Christina talked about this was being recorded, but think about what we're doing with those recordings, where they're being housed, the access to the learners. Think about your simulation design. Yes, there's some wonderful frameworks by Inaxel, SSH. I'm based in the UK, so ASPI, the UK Sim Society, a bit of a plug for them, CSAM. The mode of simulation with digital, you know, we could use augmented reality, virtual reality. We're going to see some of that. We can just do this whole approach. You could use filming from an interactive mannequin or using a standardized or simulated patient. Are you using it for teaching? For assessment? Think about our learners. I think, and I do believe from some of my experience and Diane's, that you need this pre-encounter learning. So this marriage of skills, theory, so that when they come to the virtual environment, they're better prepared. And maybe this is a way, a segue into certainly doing this when the post-pandemic era begins. I do believe there will be one. We have the simulation. Again, in the digital world, how are we going to interact? Are they going to switch on their mics, use cameras, use chat boxes? We need to think about how we're going to do this. Think about, are we doing feedback or debrief? And also, it's all very well doing the most beautiful simulation activities, but how are we going to measure that learning? What is our evaluation tool? And maybe think about reflection on action. And if you have a learning management system, maybe somehow incorporate that. So I said, when I talked about Martin Weller and talked about Boyer, we talked about this networking piece. And part of this is the learners have a responsibility. Now, our learners could be at undergraduate or postgraduate level, but they need to learn the tools. And as you saw by the slight technical hitches, we need to build that in. So what can you do? They need to be aware of your IT policy, but also things about access. How access are we, the accessibility for learners with visual issues, with hearing issues in this digital world? What safeguards can we put in for them? They too have a responsibility for their pre-encounter learning. I do believe passionately, and I know many of you do, that in healthcare, it's not just get your qualifications at undergraduate or postgraduate, it's this concept of lifelong learning. So we really need to think about that. And again, we're role modeling good practice. They do their simulation piece, whatever that looks like. And again, are they having feedback or debrief? And finally, that post-encounter learning. So if we think we've got to do all of that as digital scholars, that's an awful lot of work. So let's now begin to focus towards Maestro Evolve. What I did recently at college was a research project around virtual reality. And it's really interesting, all the different definitions. Are we using 2D, 3D? Do we have learners wearing devices? And again, all of these, there's lots of wonderful definitions in the second edition dictionary. But what we really want to do is, how can that technology be best used for us as faculty and the learners? Because at the end of this is all about safe patient care. So now we're going to move into Maestro Evolve. And what my cunning plan is to tell you what it is and then take you on a journey using all of the equipment. So Maestro Evolve. Now, some of you may already be part of the CAE family or considering joining it, may already be aware that many of our mannequins use software. Some is called Muse, but the current software where we're doing a lot of developmental work and everybody's on Muse, we're moving forward, is Maestro. And this software runs many of the simulators. So if you by chance have seen an Aries or a Juno or a Luna, you're used to this wonderful physiological and pharmacological platform. And an example I mean by Physiological is if the patient becomes hypoxic and the learners do not give oxygen as part of their scope of practice, then the interactive mannequin will deteriorate. But when oxygen is given, depending on the percentage of oxygen, the blood gases will change, the respiratory rate will change, the saturations. So many of you may be aware of that software. And then currently, there's the standalone software. And certainly since March, I've been doing a lot of teaching with this, just using this software very simply to recreate clinical situations. Again, it's the same software. So what is Evolve? Well, here's the cool and trendy thing. Evolve is the Maestro software. So if you already know how to use it, you don't have to learn a whole new set of skills. But this is the absolutely brilliant thing. It comes with a lovely virtual patient. We're going to meet the patient very shortly. It will come with a range of simulated clinical or simulated based experiences and virtual equipment. So we've created digital twins of a range of equipment, which I'm going to show you, and then I'm going to use it. I'm going to play both facilitator and learner, because I wouldn't want to put any of you to have to do this. It wouldn't be fair or appropriate. So this is what it looks like. Imagine you as the facilitator, and instead of having to download loads of software onto your computer and think, oh gosh, does it need updating? Instead, you log into the cloud, but also the learners. Now, there's only 2 learners in that lovely graphic, but there could be many learners. The many learners also have access to the digital twins. So they have access to the monitoring, the defib, the ventilator, and the virtual patient. So instead of you as the facilitator saying, what would you do? And the learners say, oh, I'm going to put an ECG on here. I'm going to do a saturation on here. Instead, they can do it. And I'm going to show you how this all works. So they actually are able to do skill rehearsal, making their own decisions using the digital equipment that you allow them to have that are appropriate to those wonderful measurable learning outcomes and their scope of practice. And even cooler than that, any simulations that you develop actually can then be exported into your Maestro-based simulator. And I was working with Gary from Iris, who's done that online authoring tool that I know many of you may be aware of. And we've actually written a case in Iris and exported it into Maestro Evolve. So again, it's just such a wonderful way to really bring learning alive. So just imagine you're here, you log into the cloud, then you give the learners links and they can log in, and you can do this wonderful interactive session. And that's what we're going to see in just a couple of minutes' time. So I just wanted to show you some screenshots of what you see before we see it live. So this is the login screen, and this is what you as the facilitator see. And you have the wonderful software. This is the same Maestro software that runs many of the mannequins. Again, this lovely physiological model, the pharmacological model, the half-lives of the drugs are accurate. So if they give a bolus of a drug, it washes in, it washes out, and all the parameters change automatically. So just the same as what you've been used to if you've been using that technology. The patient monitor that we call Touch Pro. Again, the same system where you can do things like 12-lead ECGs, you can have different settings. But now we have the new bit. You have the potential to have a virtual ventilator. Currently, the ventilator is platform agnostic, but in time, will be able to be adapted to current models. So again, the learners are seeing the same what they see in practice. The virtual patient, where the learners can do assessments and can actually do procedures on. And this is what the learners are going to see, is you share the links of the equipment that you want them to use that's appropriate to the type of patient they're looking after in the clinical context and to their scope of practice. and you get to choose that. So what I want to do now is actually go live to the software. I'm going to walk you through it. So you've seen my fantastic, wonderful computer skills. And what you're going to see now is an example of CAE Maestro. So this is the software live. So you can see here that my patient is a Mr. John Smith. Being British, I went for a very British name. So Mr. John Smith, he's a 58-year-old gentleman. And this screen is the same as what you would use. So for example, you can change things like respiratory rate, heart rate. You can also give intravenous medications, oral medications. All the doses are accurate. We can do things like fluids and oxygen. So this is the same screen that everybody sees. What I've gone ahead and done ready is created a very simple scenario. Currently, we've got normal physiology, but we've got a patient that we're going to see shortly who's going to arrive in the emergency room with chest pain. I would get my learners to assess the patient. Very sadly, he is going to have a cardiac arrest, but he's going to live. It's going to be okay. Then we'll see him after his arrest. Then he will need some procedure. I was a bit vague with what procedure, but again, depending on your context, he is going to need a little bit of ventilation. Then he can be extubated and stabilized. So this is just the same as I would to run an interactive mannequin. But here's the difference. At the top here, I'm just gonna, I think the software is just reloading again, is the virtual patient. So we're just loading. So yeah, we're just reloading our virtual patient. We've also going to, so as you can see, it loads really, really beautifully quickly. Patient will arrive very shortly. We have our Virtual Touch Pro. So this is just the normal monitoring that many of you have already seen. I'm just going to switch off the alarms. And I think what our slight technical hitch at the beginning, maybe my, in the village that I live in, we may have had just a slight bit of a internet. So I'll just reset that up. So we have that. We also, what's now loading is my next piece of virtual equipment. This is going to be the virtual defibrillator. So that's just going to come online now. And the learners get these links sent to them and they can be copy and pasted into Zoom, Microsoft Teams, Adobe Connect, and then finally, the virtual ventilator. Now, the learners would not see this Maestro software screen. This is the important piece. What the learners are going to see is Embody and the virtual equipment that you would like them to have that's appropriate to what they're doing. So I'm seeing this screen as the facilitator. They're never going to see this screen. I'm going to show you everything tonight so you can just sort of see the magic. And there's our lovely patient who's arrived. I'm going to sit him up. And this is, imagine now here, the learners actually have the ability to actually change position. So we're going to sit up the gentleman. So there he is sat up. We can do various things. We can maybe, for example, check his pulse. When I click that, again, there's his carotid pulse. I can measure. Got a lovely, I haven't started my patient yet, so we've got lovely fit physiology. You can change the different views, so the learners can have different views. So maybe a sort of helicopter view to look at the whole patient. Or we can have a close-up of the gentleman's face. And this is a gentleman tonight, but again, we've got different cultures, different ethnicities, because that's clinically appropriate. We can also do various things like measure his ECG, for example, his blood pressure. And then the lovely thing is, it actually then links, there's the monitor, it then links here. So that is his current monitoring. So the wonderful thing is that you as the facilitator can run the case. The patient will evolve, vital signs will change, and then depending on the learners can then use their monitoring and begin to treat. So without further ado, let's have him arriving in the emergency room with a little bit of chest pain. So again, what would I want my learners to do? Well, I want them to do some wonderful assessment. They can count his respiratory rate, but also, and I'm a cardiac nurse, so that's why I wanted to choose something cardiac-y for us, is what I would like to do is maybe do a blood pressure. So again, imagine the learners seeing this screen now. They can do other assessments. So maybe they go for a manual blood pressure. They might decide, you know what, maybe it's appropriate to do a 12-lead ECG. Well, guess what? They can. And the great thing is that this 12-lead ECG is generated at that moment in time. So, you know, I'm not having to send anything. This is whenever they're ready to click, the Maestro physiological software generates that lovely 12-lead ECG. Now, this is the bit that when I was first looking at this, and I think as a facilitator with anything in simulation, there's a tiny bit of a learning curve. Even though I've given my learners all the equipment ready, there's a little bit of housekeeping that we as faculty need to do. What we need to do on this side of the screen is go to the equipment. So I'll do this bit very slowly. Here's all my lovely equipment. So the first thing I know is going to happen is he's going to need some electricity. So what I do as the facilitator at the back end of this, remember the learners don't see this screen, is I can choose what type. So I'm going to go for 3 leads and I'm going to go for pads. Just switch that on. That's now the learners still don't have the defib, it's still not yet switched on because they're going to have to switch it on. They're still seeing the lovely ECG. And when I am ready, I will move the patient into the next state, that next chapter, that moment in time. You know it's cardiac arrest. I'm sorry if I've ruined the surprise there, but so here it is, cardiac arrest. He's going to go into cardiac arrest. So again, the learners don't see this. They are seeing the touch pro. So they now see cardiac arrest. What do I want them to do? Well, again, call for help. I have switched all my alarms off for you today. He's not looking so great. I think we can probably agree that. Well, maybe we're going to lay him flat. We can actually start doing some bag valve mask. I'm going to go lots of UK practice here. I know I've got some UK folks on. He's still in VF. Maybe help has arrived, or maybe it's them. They can now, they have their defib. Well, first thing you want them to do is switch on. And the great thing is they are doing this. I'm going to go for analyze because that's push analyze. And hopefully if you heard that voice, push analyze. So again, I'd set it up for them to use the pads based on their scope of practice. So if they don't actually have said they've put the pads on, I wouldn't have ticked that. I did that slightly ahead of time. Well, we're going to analyze.
Analyzing now. Stand clear. Shock advised.
So
stand clear. Press shock button.
So again, the learners have to decide, are they going to shock or not shock? Yes, we want them to shock. So just before I do it, I want to show you what I've done here. When they give the defibrillation, automatically he is going to recover for today. He will go into a return of spontaneous circulation. So I've already set that up. Remember, they aren't seeing this screen here, but the minute they shock him, he will change his physiology. So we'll go back to the action. So here we go. We're going to do the shock.
Energy delivered. Shock CPR.
So now they would carry on, but they need to check there's been a change in rhythm. So I'm just going to switch that off just for us. They're checking. There is a pulse. They need to go back and assess the patient as always. So for this, hopefully you're seeing you get some really nice storyboarding. Look, he's begun to breathe again. He's feeling slightly better. They're going to do some more assessments. What would I like them to do? What's best practice? So always go back to what's best practice. Well, again, do some more vital signs. His oxygen level isn't so great. So what would I expect them to do? give oxygen. So again, as they're doing it, I can, again, use my lovely treatments here. Depending on the level of oxygen that they're giving, I just matched them. I'm going to go for beautiful, very, very high percentage for us today. And again, the physiological software will respond to that in real time. So the wonderful thing about this is, as a facilitator, they're doing all the actions that you would expect in your lovely face-to-face sim lab, but we're now doing it in this lovely virtual world, and the learners are using the equipment. They're beginning to practice, do that skills rehearsal, do that mastery. You'll see the saturations are coming. All I did was give oxygen. I've done no other thing at all. And this is the wonderfulness of using a physiological mannequin. So again, they can go back, they can reassess. I'm just going to make sure that I get my tabs in the right order for you. And now let's imagine we're going to move the story on that for whatever reason, he needs a little bit of intubation. I just wanted to show you all the lovely equipment today. So he needs to be sedated. Well, we can do that. So the first thing I'm going to do is I've created just a sedation. So we're going to sedate him. What do we want the learners to do? Well, again, we're back to our old friend, the bag valve mask. So that's back on. So just put that back on for them. But now I want them to maybe practice their ventilator settings. I have my virtual ventilator ready, but this is where this is so fantastic from you as a faculty person. I have my lovely virtual equipment, which again, they don't see this page. It took me a little while to figure that piece out. And this is the ventilator. Now I can choose what type of ventilation, ET tube, for example. I can decide the mode. There's various modes available. I'm going to go volume control tonight. I'm not a ventilator expert. I can decide things like PEEP, but also what you can do, depending again on what you're trying to teach. I'm thinking about the pandemic. You can do complications. So you can maybe have that there's a leak as an example. So again, you can really get them to really practice all that different ventilation in a really safe environment. So I'm just going to, and you can apply different changes, different gases. So I'm going to just set this up a little bit because I'm going to ask them to do some settings. But hopefully you're getting an idea of just how really flexible this is. And then we're going to have him ET tube. And because of that, I can now make Mr. Embody put an ET tube in. We're still on bag valve mask, but as we go to switch on the ventilator, they can set that up. So for me, what I've been finding is you need to have a really effective simulation design. Really think about, I'm showing you all the virtual equipment, or an awful lot of it today, and there's lots more coming. So you don't have to use all of this virtual equipment, but I just wanted to show you that you could potentially do the most wonderful patient journeys that really focus on different aspects of critical care, or maybe the role of the registered nurse, or the role of the CRNA, or from an anesthetic perspective. So maybe we should start ventilation. I'm just going to silence my alarms. And again, I can set. So, I want them to do some settings. So I'm just going to take down my respiratory rate a little bit. And again, the learners, they have access to this screen. What can happen is they can practice, what is the role of the registered nurse for ventilation? What's the role of the doctor? And so on and so forth. So you can do some really, really, really wonderful things. So just going to go for there. And the lovely thing is about this, you can have different views. So depending on what sort of data your learners normally see when they're using your types of ventilators, so maybe we're going for loops and graphs as an example. And again, I'm not going to put any ventilator complications in, but I could. So you could really begin to manipulate to try and get the best ventilation. So some really, really wonderful things here. And as I switched on the ventilator, you'll see that automatically Embody, it automatically changed to mechanical ventilator. So again, Embody is linking to this physiological software, Maestro, and linking to all of the virtual equipment. So it's all linked together. So you're creating this wonderful virtual world. Just going to switch off my alarms again. So let's now imagine that Embody's had his, Mr. Smith has had his wonderful procedure. So actually I'm going to want to extubate him now. So I'm going to go back to bag valve mask. There we go, beginning to wake him up. I'm going to stop my ventilation. And the really lovely thing is if the learner switch power off, you know, are you sure? I am going to switch the power off for us today. And then what I can do is move him to the post-extubation state. And again, they can do all those lovely checks and things. So now he's had quite a busy journey. He's feeling a lot better. I'm going to sit him up again. So I have him beautifully sat up, and I can begin to carry on the appropriate care for him as he is. And then say to the learners, what would you do next? And again, so you're just linking all of this together. You're linking their assessment skills. They also have to use their critical reasoning to really think about which equipment and also how to safely use the equipment. And the really fantastic thing about Maestro software is you have these checklists. So you can actually, if you wanted to, yes, we're doing it for teaching and learning, but you may decide by the level of the learners that you might actually decide that you want to do more formative assessment. If that happens, you can create your own, but maybe you give your learners numbers, and you can begin to assess, you know, did they identify that this was Mr. Smith at the beginning? Did they demonstrate cultural sensitivity in hand washing? You could have one for PPE, you know, did they do the donning and the doffing procedure? You could also have one, for example, on the defibrillation, you know, when they did that, did they identify it was a shockable rhythm? Did they call for help? And so on. And all of this can be kept afterwards for maybe more of a formative assessment. So you have the ability to have checklists as well. The other thing that we could have done is in our patient records, I could have put here blood results, referral letters, ultrasound. So if it was appropriate and the learners, for example, it was trauma and it came in for a fast scan, what we could do instead is show them a film clip of somebody with a splenic bleed, for example, then they have to treat the patient. So what I'm trying to get across is this is just such a really wonderful way of actually linking theory and practice. So you'll be very pleased to hear that John Smith, or our virtual patient, is doing okay. He's looking a lot happier. For me, I'd go and get him a cup of tea, but maybe that's how I like to practice. So what I just wanted to do is, just because at the beginning, and I think it may have been my internet, I just wanted to show you the Boyer's model piece, because I just think it will make more sense if we just showed the graphics. I'm just going to go back and show you that just for a minute. This is what I was trying to explain about how all of us need to evolve as simulation educators, both in relation to the pandemic and to some of the work that we've actually found is this concept of new ways of thinking, new ways of delivering our simulation-based education. And networking, we're a global community. I'm a big fan of Etienne Wenger's community of practice work. If we start sharing how we can use these technologies to improve patient care, quality and safety, that blended learning, you know, the pandemic has really accelerated the virtual move. So maybe we start using virtual simulation prior to face-to-face simulation. So again, it becomes part of the continuum, what I like to call the new hybrid in the new normal. And then thinking about our transition, we're going from sages on the stages to guides on the side, this concept of digital scholarship. And our learners become part of this journey. And for some of us, and for me, digital literacy, you know, learning what to do when things go wrong, learning how to keep going, learning all the different technologies, the support of our technologists, our e-learning specialists, and also new ways to resolve today. And, you know, often people talk about the theory practice gap, but maybe it's also about the practice theory gap. So things are evolving. So what I'm just going to do is, just because I don't want to scroll through a load of slides, because that would be really, really horrid for everybody. And this is Diane and I who have done a lot of this work together. This is one of our favorite quotes. We say that learning It's not attained by chance. It must be sought for with ardor and attended to with diligence. Abigail Adams, related to John Adams, an early president of the US, said that about education. And for me, if we're going to teach in this digital way, we really need to think about using the right technology in the right way for the right level of learners at the right time, and really thinking about what can we do to enhance that learning experience. And for me, using the digital twinning technology, the virtual defib, the virtual ventilator, the learners I've been working with, it's transformed because they're actually able to do it. They can all have a go because you just send out the links to all the students. So what I've tried to do is talk a bit about digital scholarship. If you're really interested in this, Martin Weller does a lovely blog called Ed Blog Tech. I've tried to demonstrate some of the ways you could actually use Evolve and try to show that I'm really enthusiastic about it. I'm still learning it and still trying to push the boundaries. I really think the benefits are, it really gets the learners involved, but also the learners can actually have a go and have that professional play. They can begin to understand how to use the equipment, when to use it in a very safe way, so that when they do go back to maybe face-to-face simulation or face-to-face patient care, they actually have an understanding of the whole piece. And also that you can really design any type of patient that interfaces with any healthcare professional using this technology. I chose quite an acute patient today, but you could do something in the community, you can do something in a GP surgery, in a hospice, and you just use the right level of equipment that's appropriate to that right patient. So what we wanted to share, just gonna, oops, just before I do my goodbye slide, so is virtual, non-virtual. So that was the presentation. The pictures, just because we had a slight technical, the rainbow has been used across the UK as a way to celebrate key workers, particularly those in the NHS. So if you're wondering why I put that there. And the second picture is the leaflet that we all had, and a letter from Boris Johnson, the Prime Minister of the UK, about coronavirus and the various lockdowns that are still continuing. So that was a very sort of little piece about the UK. So with that, I'm going to pass it over to Amar. I do apologise for the technical hitches, and but the Evolve piece worked beautifully. So there's my email if you'd like anything. So over to you, Amar.
Thanks, Mandy. This is fantastic, right? And so you've tons and tons of questions here. So certainly going to kind of kick it back over, and I've got a bunch of questions for you from many of our folks here that want to ask you a bunch of stuff. And I think first and foremost, you know, what content can be converted over to Evolve, to Maestro Evolve, right? So can you talk a little bit about existing content that can be brought over, or new content that's being developed into Evolve?
The really exciting thing, and please as well chip in as well, Amar, is Maestro Evolve. We've actually done some wonderful work with the physiological model. We've actually done some wonderful work with the lung piece. So it is some new type of Maestro. It's got a 2-lung model, which means you get these most wonderful end tidal, because that's something we've had from the community. So I'm going to say for Maestro, it's the latest. It's got the most up-to-date physiological model, but you can use a lot of the work that you've already done within the Maestro family. So you can use a lot of that content. But Amar, you know slightly more about that, because that's more your piece.
And a lot of it is, so existing today, right? Juno and Aries, easy to convert over. So there are existing scenarios within those platforms that you can easily bring over. In addition to that, one of the other questions that was certainly posted by our audience members, by those joining us, is certainly around the labs and patient records and other things. Once it's part of the scenario, it's part of the scenario, right? So it becomes encapsulated within it. And you can play a video within the software platform, right? So I think you were showing the touch Pro on the screen, so you can actually share a video of an ultrasound or a CT or something else that you want to throw out there. So as well, right? So I think there's a lot of neat stuff there. Interesting question about patient communication. Any advice? Sandra asked a question around How do you communicate through the patient to the learner? Is that possible today?
Yeah, that's a great question. I had that earlier today on a slightly different webinar we were doing. So I think if you have a second faculty member that can play if you're using an interactive embody, if you have a second person that could play the voice of the patient, I think that could be incredibly effective. It could well be you. The other important thing about that is also the interaction with the learners and you as the facilitator, because you need to put some ground rules in about them. How are you going to get them to chat? You're going to, as we've done today, mute everyone or allow people to mute. The other thing I've been experimenting with is if we're using this sort of type of teaching, is at certain points in time, you may pause the simulation activity and put the learners into chat rooms and get them to do some group work and then come back. So I think it's a combination, but I think certainly if you're using Embody, the virtual patient, one of you could easily voice that. And I think that would be incredibly effective.
Yeah, and along the same lines, I think creativity oftentimes involves. It's always good to have a backup in these sessions. I know that's not always a luxury that you have, right? You don't have always more than one person available to do these, but redundancy always plays a role. And if you've got that extra person, even able to play the role of the patient, use them, right? Be the voice. It helps bring that animation to life a little bit more. There's a question about updates or ways to change from use to Maestro. I don't know if you want to take that or if you want to jump on that.
Yeah, because it's Maestro in the cloud, Maestro Evolve, whenever you log in, you're always going to have the latest. So it's constantly updated. And why that is really important is as the more and more virtual equipment, we're working on some fabulous stuff that I'm not allowed to say. Emma may be able to, but I can't. So as more virtual equipment gets developed, every time you log in, you're actually going to have access to that the whole time. So that's why we called it Evolve. It's evolving. So you always get the latest, greatest, up to date. No more of this, have I got the right software update? Do I need this? You log in, up to date.
And you don't need your Mac or PC that's tied to your simulator, right? So that's a completely separate animal. You can just use the web-based application. We're using a PC in the office. Mandy's using her computer in the UK. So, the nice thing is any web browser capable machine can jump on and run with it, which is great, which is fantastic to see. Talk a little bit about IPE. Like there's a lot of focus and questions around interprofessional education, right? Especially with some of the things that you were showing around ventilator, monitor, defibrillator, the patient. Can you talk a little bit about that perfect interprofessional education?
Of course. Thank you. It's a great question. The great thing is you can do proper IPE here. Part of the issue in our traditional simulator way, using our face-to-face rooms, is we had the medical school, the nursing school, technology, we couldn't get timetable. Now you could actually set up proper clinical teams at either undergraduate or postgraduate level, so that you could have initially a group of nurses, doctors, maybe some CRNAs. So the patient, in my example, arrested, they call for help. They get the crash team. They get those learners playing their roles, where they may be student roles, student doctor or qualified, and they do the roles of their professional. So then they begin that teamwork piece and begin to do those clinical decision making. So this breaks down all those silos of medical school, nursing school, paramedic school. And again, also thinking about, you could start this off as a paramedic ringing in and they're expecting that handover. So you get these beautiful patient journeys. All the professions are doing the right thing. We're not role playing or you pretends to be. So the great thing is, if you look at all the IPEC competencies, for example, we can have real clinical people doing their real clinical roles, but within the virtual world. So in the UK, not every nurse can do defib when they qualify. They call for someone that can, or the doctor. And if the doctor has to wait, they wait for the doctor or the crash team to come. What do they do in the meantime? So again, we can recreate clinical practice, a proper mirror for the first time.
Yeah, it's a great handover too. So there's certainly a good communication. There's a great question around incorrect measures and techniques, right? So how does Maestro Evolve tell a person they're doing something wrong? And I think that goes back to your feedback question around physiology, right? So so I think you showed two things, and I think it's important to talk about these. One is, how does the physiology tell bad performance or behavior? And two, how does the checklist also help?
So we'll do the physiology first. So let's just imagine that the patient is becoming hypoxic. and the learners give oxygen, but they choose to give nasal cannula or nasal specs, which is within Maestro as an option. The patient doesn't improve their oxygenation. In fact, the patient gets worse. So again, you have that physiological prompt, just like you would in clinical practice. Real life patients deteriorate. So the learners see that life, but then you could have a checklist around assessment or management of whatever it is you're doing. And you could designate which learner it is, begin to do the checklist approach. At the end of the simulation, maybe go into more of a feedback where you could actually bring up that criteria. But then what you could do in this post-encounter learning is maybe have those checklists and something like learning space, and as an example, where the learners could actually look at their film clip, because all of that can be captured, and self-assess as well. So again, they're beginning to understand where their learning gaps are, what I often call drop stitches, and then you can help them figure it out. So you have two approaches. You have real life patients deteriorate when things aren't done correctly. Maestro does that automatically, it's inherently built in. And you have those checklists that you can use after the event, but also if you film the whole thing, they could then do a self-reflection and begin to build up their learning prescription.
Yeah. So you have a complete cycle. And one of the questions I had on here, which is always a good discussion for debate, is around competency, right? And so in this digital ecosystem, in this digital world with Maestro and Maestro Evolve, how does competency play a role? How are we able to look at an individual's knowledge and ability? And do you want to, I certainly have my opinion. Do you want to share yours a little bit on how that can play a pivotal role?
Well, the great thing is because the learners are using the equipment, they can't fake the learning. So individually, they're making those choices. And what you should begin to see, I'm a great fan of cognitive apprenticeship, is that they get quicker and quicker. So, and what you can see as a facilitator, if there's hesitancy or a delay, which may come out through the debrief or how you do your feedback, you could then use this as a teaching piece to actually role model to do that scaffolding piece until the learners, again, do it again and again. You get that repetitive learning. You can do it very, very quickly. We're not having to have a book the sim lab again. We're in the virtual world. We can keep doing it. So again, it's a combination of the learners practicing, and maybe it's the first time they've switched on that equipment, and it might be that when they're in the simulation lab or in the clinical practice, they've never been able to do it because there's always maybe a more exuberant person there. So the learners have their own equipment. They cannot fake it. But if they can't do it, you're able to see that, and then you can do your scaffolding strategy to bring them up to speed.
Yeah. And the software, one of the questions in here, is this for self-directed or instructor-driven education, right? So do you have to have a facilitator on the back end, or can the student go play around themselves?
I would say it depends on the level of the learners. I certainly think there's no reason why you couldn't have more experienced learners actually doing this themselves and doing it in small groups as a great student project, that they can design something and do something. So I think students could do this. I think you would need a facilitator, not to actually maybe do some of all that extra work I was doing, but more as a moderator, more as a coaching framework. But yes, I think that would be a great strategy to try. I hadn't thought of that. So that's something that I might just take off you. So thank you for that super idea.
There's this notion, and I don't know if you guys have started to hear it, so especially as we look at the digital acceleration, right? So the last 6 months have been crazy for all of us. And you guys are certainly living it every day. There's this notion of what's called facilitated instructor-led, which is the notion Andy's getting towards, where you have a facilitator in the background, but the students are actually guiding the learning experience. And a digital world where individuals are interacting from different areas, especially like in this environment, the instructor plays a larger facilitation role, make sure that students are staying on track, but not necessarily doing core teaching. So it's more that facilitative. There's this notion of FILT, which is new, and the concepts and some of the interesting stuff behind it is very, very new. So really interesting stuff there. And then we've got, I know, about 2 minutes left. Questions around certainly can non-CAE centers use this as an ICT solution? I think your answer to that question would be sure, right? Absolutely. There's no risk there for that, and it's a web address, right? As you said, it's on the web, right? I mean, unless you see something challenging, but I don't see anything where a non-CAE center could grab it, and we can certainly put you in contact with the sales team on that side. And then certainly one of the questions you had were around cost. We'll certainly, if you've got any questions around cost, certainly send us a note. We'll happily make you in contact with the right team. On the education side of the house, it's something unfortunately we don't have off the top of our head. So, And then last question for you, Mandy. Can this be used asynchronously as different students in different programs have different tasks to do at different times?
I think potentially, yes, there is a way of doing that. I think it depends how you do your simulation design, but I'm sure there is a way of actually doing that. The issue is that it is in the cloud, so potentially, my question would be, would you need to do it asynchronously because it's in the cloud and it's available 24/7?
And there's a question on age and gender. Want to talk a little bit about that?
Yes. So, do you mean in relation to the physiological software or relation to Embody?
The patient, the representation of the
Yes.
patient.
Yes.
Can it be a male versus a female?
Yeah. So, as Embody, you will be able to have different types of patients, different physiological patients, different genders and different cultural groups. The other thing that you can do as well is, even though Embody has parameters within Maestro itself, you can create different baseline physiology. So what you can do, and I've done it when I've done my work in Australia, is in Australia, Aboriginal health is a big issue for cardiac disease, particularly in their 30s and early 40s. So using this software, we created an Aboriginal physiological person and then did scenarios on top, because it's very, very different to someone who is not an Aboriginal person. So you can create different patient profiles on. So if you work in an area where you see a certain characteristic, maybe due to social issues or cultural issues, you can create those virtual patients with that physiology. So the learners can see that actually, for somebody from this culture where they've got, I'm just trying to think of an example. When I was a student nurse in London, we had a large member of patients that had sickle cell disease. Again, a very unique population. So again, the way we would treat them with a chest infection, we had to be more aggressive with our oxygenation. And again, the learners needed to learn that. So you could create wonderful physiological different patients. So not just the animation, but also the underlying physiology. And if you have Lucina, which is our birthing simulator, she has the physiology of a woman in her last trimester, very different from our normal elf female, our normal human lady physiology. So we do already have different physiological profiles. And the same in Luna, the baby simulator. You choose either within a few hours, within a day, within a few weeks, because again, the patient changes based on those different physiological types. So we can already do that.
No, thanks. Appreciate that information. And I think we're approaching the top of the hour. Just throw this out there. Our next CA series is on October 21st at 2 p.m. Please sign up for that. And also, if you're interested in learning more about some of the stuff that's going on, jump on the podcast at www.cahealthcare.com/podcast. And then we appreciate your time. And certainly, Mandy, thank you so much for taking the time today to join us and share everything about Maestro with everyone that jumped on. And then we'll certainly catch everybody else the next time around. Olivia, thanks to SSH for allowing us to be part of this.
Thank you. Thank you, everyone. Stay safe, everyone.